Okay. Good morning and good afternoon, dear all healthcare professionals. I'm Mao Hua from Jianfeng, in charge of the marketing part. So first of all, welcome to the Global Renal Absorption Connect Europe session. So first of all, let's welcome Dr. Edgars from Latvia. Dr. Edgars currently he serves as the head of extracorporeal unit and Strandings University Hospital in Latvia. He is also an ECMO specialist with extensive hands-on experiences in the continuous renal replacement therapy for more than 7 years. And in addition, Dr. Edwards works as a hemodialysis specialist and SIA Med ALAA Hemodialysis Center, bringing together deep clinical experiences across critical care, dialysis, and extracorporeal therapies. We are very honored to have Dr. Edwards with us today to be our moderator. So welcome, Dr. Edwards.
Good morning and good afternoon to everyone. And it's a great pleasure to join you today as a moderator of this session. And I'm pleasure to open this session, and we are truly delighted to have you with us today for this important forum designed to provide valuable insights into the latest advancements in clinical practices which focus on dialysis-related complications, with a particular emphasis on hemoadsorption. And it's our privilege to welcome these distinguished experts from across the EU region who will be sharing their invaluable knowledge, clinical experience, and perspective throughout the session. To start, it's my great honor to introduce Professor Giuseppe Castellano, Chief of the Department of Nephrology, Dialysis, Kidney Transplantation, and CCSCA Grande Ospedale Maggiore Policlinico, Milan, Italy, and Associate Professor of Nephrology at the University of Milan. Professor Castellano is a highly distinguished nephrologist with over than 210 peer-reviewed publications, more than 5,000 citations, and an age index of 40, reflecting these outstanding contributions to nephrology, dialysis, and kidney transplantation. Professor Castellano has also led multiple national and international projects, received numerous awards and fellowships, and serves on the editorial boards of leading nephrology journals. His expertise and achievements have had a significant impact on advancing patient care and shaping the field of nephrology worldwide. I am pleased to invite Professor Castellano from the University of Milan, who will chair today's session and provide opening remarks.
Thank you very much, colleague, for this great introduction, and good morning to all the distinguished guests, colleagues, and friends. And I would like to welcome everyone to this European Adsorption meeting. It is for me a great pleasure and an honor to open today this session. And in this session, we will gather to explain all the advancement and regional practice in the patient-centered management of the dialysis-related complication using hemoadsorption. I think that this topic remains highly relevant and is impactful in improving the quality of life for our dialysis patient. Today we have a very nice agenda that brings together insightful keynote presentation, very important presentation today. We have a case sharing and a thought-provoking panel discussion that is really important, featuring leading experts from across the region, the European region. Thank you again for being here with us, and I look forward to an engaging and productive session with you all. So let's us now begin this journey, this scientific journey all together. And thank you very much.
Thank you, Professor Castellano, for that insightful introduction and overview. Let's now move to our first presentation. Next, it's my pleasure to introduce Professor Mario Casalino, full professor of nephrology at the University of Milan, director of the nephrology department at San Paolo and San Carlo Hospital, Milan, and head of experimental nephrology laboratory at the University of Milan. Professor Casalino is a leading authority of nephrology with remarkable academic record, having authored over 330 peer-reviewed publications with a total impact factor of approximately 850, over 8,800 stations, and age index of 50, and I-10 index of 180. He has served the chair of European Renal Best Practice and led the CKD MBD working group or ERA ADT, and is a distinguished fellow of both ERA ADTA and SN. He also contributes extensively as a editor and editorial board member for multiple international journals, including Nephrology, Dialysis, Transplantation, Scientific Reports, PLOS ONE, and Clinical Kidney Journal. Professor Casalino's research has profoundly influenced in clinical nephrology, dialysis practice, and mineral bone disorders, advancing patient care globally. We are privileged to have him here today as a key speaker for our forum.
Thank you very much for this introduction, and thanks for inviting me in this working progress in Hemoadsorption. So I would like to have my first slide with my title. So today I'm going to talk about Hemoadsorption in dialysis-related complications, advancing uremic toxin classification, and patient-centered management. So why this is extremely important today for our patients. Next slide, please. Well, chronic kidney disease, CKD, is a very common disease worldwide. This is a picture that was published on Nature Review Nephrology in 2024 on the 2023 global CKD prevalence that was rating in 9.5%. And the map of the world demonstrates that the ranges goes from 4% in Africa to 12.8% in both Eastern and Central Europe. Next one. Why is it important to take care of patients on HD? Well, because they have signs and symptoms of end-stage renal disease, the uremia, the milieu. And we know that, for instance, is present in 74% of our patients, such as hypertension, 80%, inflammatory disease, 63%, and restless leg syndrome in 34%. So these are complications that are common, but more importantly, two more that are in red in this slide: pruritus, 40%, and sleep disorder between 50 and 80% are growing and growing, and have an impact in the quality of life of our patients on HD. Next one, please. So one of the problems for nephrologists today is symptom management. So where KDIGO, our guidelines, put the symptoms? Well, the improvement in patient clinical symptoms has become increasingly significant. So assess and focus on symptoms most important to individual patients. And prioritization in symptom management should be based on patient perception of which symptoms are most negatively impacting their life quality. And we are looking for biochemical parameters. If we think about secondary hyperparathyroidism, we talk about inter PTH, we talk about beta-2 microglobulin, many of these. But still, we are looking for good biomarkers to go for a good relationship with symptom management. Next one. Let me start with the history of uremic toxin classification. This is the work by UTOX, a working group, more than 20 years ago, in which Raymond Holder, with other colleagues, were able to put the first classification looking at the important variables at the time: molecular weight, protein binding characteristics, and concentration variability of toxins. This was made to optimize uremic toxin clearance strategies and personalized blood purification protocols. So there were three groups: small molecules, 45 types, medium molecules, 22, and protein-bound toxins, 25. And you can see here that the family of toxins that were defined at the time, more than 20 years ago, was that a small molecule, most are water-soluble, can be cleared through conventional dialysis. For the medium molecule, partially water-soluble, so low dialysis clearance rates. And at that time, for the protein-bound that binds the plasma proteins, cannot be cleared by conventional dialysis. Next slide. So the summary of this classification was that the early toxin classification primarily defined toxin based on their physiochemical properties and molecular weight, a framework that remains new still today, but we will see that we need to change it. That this classification was limited by the technology of the time, and research and assessment of toxin toxicity were mainly based on concentrational difference and were not integrated with the actual clinical condition of patients. Next one. So this is why, after 20 years, in 2021, we were able to have this consensus and publish on CJSON the new classification of uremic toxins and their role in kidney failure. And we just look at the past, coming to the limitation of the old terminology to suggest an update on 4 points. So the chemical identified biological fluid, so suggested update in solute identification and accurate quantity of analysis in plasma, serum, or blood should be possible. Second one, unclear whether total body levels and uremic is not specific term, just to look at the CKD in subject with normal kidney phage function and see the difference in plasma, serum, and blood. Reduction of solute concentrations. Okay. And concentrations, body fluids or tissue, and uremic, and again, biological active concentration in the study should confirm into those found in plasma, serum, or blood, or CKD patients. Next one, please. So what we needed to do in this paper was to go, and this consensus based on 2003 guidelines outline future direction for attention and improvement in toxin classification, chemical identification, quantitative analysis, measurement of total toxin levels and plasma concentration, relationship between toxin concentration and clinical symptoms, and finally, standards for toxin concentration. Next one. When we look at the classification principle based on toxin clearance technology, the limitations of molecular weight-based classification for the cutoff points based on molecular weight that were artificial set, making traditional toxin classification overly simplistic and unscientific, impact of protein-bound toxins on clear efficiency, because many toxins with high protein bind rates cannot have their clearance efficiency accurately predicted based solely on molecular weight classification. And finally, the impact of modern clearance models on toxin removal. So the classification of uremic toxins should incorporate considerations such as dialysis strategies, absorption capacity of dialysis membrane, clearance modes, and protein bind rates in addition to molecular weight. The standards for uremic toxin classification need to be continuously updated to accommodate new clearance methodology. Next one, please. So, the multisystemic effects of uremic toxins ultimately lead to higher mortality and lower quality of life. And this slide is very of impact for nephrologists, because in the middle there are uremic toxins, and you can see all the systems, not only kidneys, not only cardiovascular system, but endocrine, nutritional, hematologic, immune, nervous, digestive system, can be impact for uremic toxins. Next one. And we know, of course, that the cardiovascular system is the major link to morbidity and mortality in our patients. So, physiochemical properties of toxin, due to the difference in the molecular structures and properties of toxins in the body, the clinical consequences they may cause are not entirely determined the physiochemical properties. Uremic toxins do not act on the body through a single mechanism, but interact through different mechanisms, and toxins should place greater emphasis on clinical consequences. And this is very important. Next one. So, this is a little bit complicated, but I will try to simplify. You can see here in ACE the number of toxins affecting specific physiological system. In BDF, the number of physiological systems affected by each individual toxin. If we want to put in three groups this, we can put in green small molecule water-soluble toxins, and these are linked to cardiovascular system inflammatory response. The protein-bound toxin, both cardiovascular, inflammatory, and metabolic system, and we have inositol sulfate, for example, here, and we have cresol here, and then medium and large molecular weight, cardiovascular, inflammatory, and bone metabolic systems, beta-2 microglobulin, FGF23, tumor necrosis factor alpha, and PTH. The cardiovascular and inflammatory systems are the most significantly affected in this picture. Next one. So we move from 2003 to 2021, and we are coming to 2023 with the 5 new dimensions for classification of uremic toxins. We have exo and endotoxins, and we need to look at these 5 new dimensions. It's not only clearance technology, it's not only clearance strategy and clearance efficiency, but there are 2 major dimensions: patient's prognosis and patient's outcome. And in this way, we can propose this new classification of solutes of interest in both uremia and hemodialysis. Next one. When we look at the possibility, a methodology of dialysis, they have different effects on toxin clearance. We started with low flux hemodialysis, in which we can move only exogenous uremic toxins and endogenous water soluble. Then high flux HD, high flux HDF, but look what happened with the medium cutoff HD and with high cutoff FG, that of course remove also albumin, that is not good for our patients. So in the red, this is the medium cutoff HD, in which we can remove almost everything. And we can remove protein-bound toxin from ultra-large molecules after binding with proteins, making them difficult to be clear with other technology. Next one. So we move from the expansion of toxin classification dimension with patient-centered treatment strategy, with toxin clearance as the means and clinical outcomes as the orientation. Next one. But we have in this new publication from my group that is from physiochemical classification to multidimensional insights. This is a comprehensive review of uremic toxin research. And because we have a new now step to consider. So from 2003 to 2023, and then moving from this, the impact from toxin properties, clearance technology, and patient's outcome. What is next? Next slide, please. Next is hemoadsorption. Because until now, we did not consider hemoadsorption. Hemoadsorption is positioned as the core and most effective technique for protein-bound uremic toxin clearance, showing promising potentially improving patient symptoms and clinical outcomes. And when we look at the table, the final table, And we look at the clearance efficiency by modality. When we have hemodialysis alone, we can remove more small molecules and less protein-bound toxins. When we have HA alone, we can remove a lot of protein-bound toxins and less small molecules. So the combination between HA and HD can give us the maximum possibility of removal. So the clearance efficacy, HA demonstrates the highest efficacy for protein-bound uremic toxins, combined with HD, could achieve comprehensive and enhanced clearance performance. Next one. So we need to call to improve the hemodialysis patients' outcome. And these are just documents coming from KDIGO and from the International Research Institute, Renal Research Institute of Vicenza. So go to improve dialysis patients' outcomes and quality of life. More comprehensive dialysis care is needed. Not only routine symptom assessment, but optimal dialysis care. Next one. So new solution for professional absorption of uremic toxin, HA130, harnessing absorption to improve dialysis outcomes and help patients regain quality of life. Broad absorption, long-term application, and a rational prescription. The broad absorption, because we have data coming from many years of experience in China, in which the early application clears multiple toxin and protects residual renal function, slow declines by 47%, zip quality improved, pruritus improved, secondary hyperpara improved, and reduction also in all-cause and cardiovascular mortality by 37%. So what we look for, cost-effective also is very important, and with cardiovascular disease endpoint, standardized HP use achieves equal efficacy at lower overall cost versus conventional dialysis. Next one. Patient's profile, uremic symptoms management with HA130. And you can see here the primary uremic complication addressed: pruritus, sleep disorders, protein energy wasting, microinflammation, secondary hyperpara, hyper beta-2 microglobulins, hypertension, restless leg syndrome, and uremic peripheral neuropathy. So with this treatment, we can go systemically and go for uremic symptom for uremia in our end-stage renal disease patients. Next one. Our recommended HA130 treatment protocol. So attack phase, 3-session week, first month, and then stabilization phase, 2-session week, second month, and then maintenance phase, 1-session week, third month onward. This is what is the recommendation of the protocol of the use of H123. And this is why, because, for example, if you look at the picture, the kinetics of beta-2 microglobulin with 3 weeks, 2 weeks, and 1 week regime was able to conserve the reduction of this protein and improve inflammation, mitigate inflammation. Next one. Next step, HA130, excellent in cartridge design and solvent integration, the coron absorption, so sealed during injection port, safety and convenience cartridge design, nanoscale encapsulation membrane, and 30-angle design. So the KHA maintain all the good removal properties of HA, has excellent biocompatibility and hemodynamic properties, easy to use, and could reduce infection and coagulation risks with minimal albumin loss, a broad spectrum absorption, a macromolecular and protein-bound toxins, helps alleviate complications such as pruritus and CKD, MBD, chronic kidney disease, middle bone disorder. Next one. This is something that we are doing in my laboratory at the University of Milano, together with the University of Padua, with Claudio Ronco. So we want to study the pro-classify analysis of urinary serum from patients treated with KI 130, Ryzen, hemoperfusion cartilage. We have this model, in vitro model, vascular smooth muscle cells, endothelial cells coming from vessels, and put on top serum of patients that were received treatment with HD plus KHA, so dialysis plus hemoadsorption, and patients on control that will have also HDF online. That is the best. And we will follow them for 6 months. After that, we will take the serum and see the pro-calcify analysis, looking at the calcification process of these cells. And I'm really happy and honored to do this study, because this will be a proof of concept that hemoadsorption can have an impact on outcomes of our patients. And we will see probably the first data of this study next year in 2026. Next slide, please. So we are going for the conclusion. Advancing dialysis care to hemoadsorption. We started with target toxins, focus on uremic toxin, protein-bound solutes to address the unmet gap of dialysis, improve symptoms, integrate hemoadsorption leads to better symptoms control, quality of life and outcome, and center on patients. Number 3, place patients at the core with individualized, needs-driven treatment strategies. Next one. So this was my last slide. I thank you very much for your attention and happy eventually to discuss with you some points. Thank you.
Thank you, Professor Cozzolino, for the excellent presentation. Your insights on hemoadsorption, deals-related complication, advancing current toxin classification, patients and management are highly valuable and will certainly inform our discussion. We greatly appreciate your valuable expertise and contribution to today's forum. It's my great honor to introduce our next distinguished speaker, Associate Professor Ahmet Mort from the Department of Nephrology, Karafaza Faculty of Medicine, Istanbul, University of Karafaza, Turkey. Dr. Dar completed his medical degree and specialist training in nephrology at Istanbul University. His research interests cover nephrology, hemodialysis, perfusion, and blood purification. He has published more than 40 peer-reviewed articles indexed in Sky Scopus, served as section leader for +1, and is one of contributors to ERA EDTA and other international nephrology conferences. Today, he will sharing his insights on modulation of pro-inflammatory molecules with PH140 hemoadsorption in chronic disease. Please join me in welcoming Associated Professor Ahmet Mort.
Thank you very much for the very kind introduction, and it was a pleasure to listen to Professor Cozzolino's very intense theoretical lecture. I would like to thank him once more. I will share my slides, and today I will do my best to share with you the practical part of using the hemoadsorption cartridges, and I would like to share our experiences with you with some references to the theoretical background. As very well said by our chairperson, I'm an associate professor in nephrology and currently working in Istanbul University, Cerrahpaşa. And I will start with sharing our first case. She was a 55 years old end-stage renal disease patient who was currently anuric. In the background, she had polyarticular gouty arthritis. You can see the degenerative arthritis here. She was a hemodialysis patient for the previous 2 years, and for the previous 12 months, she was in our center having thrice weekly high flux hemodialysis. She had a central venous catheter, and we could maintain her blood flow rate around between 300 to 400. And she has general fatigue. She has excessive itching. You can see the scratches here. And she also reports some sleeping problems. And when we look at the specifications of her dialysis, her dialysis adequacy was acceptable. And we could do adequate ultrafiltration. She was normovolemic. However, she had a hemoglobin of 8.2, despite using maximum dose of darbepoetin alpha per week. and we could not maintain her phosphorus levels in the desired range. Also, she had secondary hyperparathyroidism. She had low serum albumin levels, which we thought because of high inflammation, because her BMI was normal. And although her BMI was normal, she had lower than normal albumin levels. And she has a CRP level of 6 times of normal. Her ferritin level was normal, but still she had anemia unless she was using maximum dose of darbepoetin alpha. She had a beta-2 microglobulin level more than 40. And she also, despite being normovolemic and using 3 different drugs, a calcium canal blocker, an alpha blocker, and alpha methyl dopa, her blood pressure was maintaining in a high level. When we look at the symptoms board, I told you that she reported having sleeping problems, and when we use the Pittsburgh Sleep Quality Index, the index revealed that she cannot, she cannot get up to sleep in 30 minutes, and she wakes up early in the morning. And as an overall score, she reports that she has a very bad sleeping. And also for itching, you saw the scratches on her back. She had scattered scratches in different parts of her body, and she couldn't feel relieving even after scratching. And more importantly, the itching feeling was waking her up at nights, which was making her sleep quality even worse. So when we look back to the inflammatory burden in hemodialysis, we all know that end-stage renal disease and hemodialysis process is a chronic inflammation process, and it can manifest with high CRP, low albumin levels, decreased total iron binding capacity, and if institutional available and checked, we will see high interleukin-6 and TNF-alpha levels. And these higher inflammation is linked to malnutrition, erythroid stimulating agent hyperresponsiveness, vascular calcification, atherosclerosis, and eventually early death with poor survival. The sources of this inflammation are bioincompatible dialyzers and membranes, some uremic toxins and endotoxins, which we very strictly control and avoid. Repeated contact with extracorporeal circuits also may drive some inflammation in dialysis patients, and also infections, use of catheters, and other comorbidities like as seen in this patient may be sources of inflammation. And the dialyzers, the dialysis membranes are also developing with the recent technologies. In the past, we had low flux dialyzers, but today we have high flux dialyzers. And if institutionally available, we can perform hemodiafiltration. And as you can see, when compared to residual kidney function, low flux dialyzers cannot remove middle molecular weight uremic toxins and also protein-bound uremic toxins as well. With high flux dialyzers and hemodiafiltration, we had the opportunity to remove middle molecular uremic toxins and protein-bound uremic toxins to some extent, but it could not reach the level of residual kidney function yet. So I really want to take this opportunity to repeat the importance of residual kidney function. And no matter how at what level it is, we should always do our best to keep the residual kidney functions in our patients, because residual kidney is the best of all treatments. And it was very well summarized by Professor Cozzolino. The toxins are grouped as low molecular weight toxins, middle molecular weight toxins, and protein-bound toxins. I also should note free light chains. The free light chains start to accumulate with staging chronic kidney disease, and in hemodialysis patients, we know that they accumulate even more. And this accumulated toxins is related to bone mineral disease, to anemia of inflammation, to immune system dysregulation, to sarcopenia, and to cardiovascular complications and early death of our patients. As I told you, the dialyzer technology was improving. So for our case, which I shared, we thought if we could change the dialyzer to have some better outcomes. We know that there are medium cutoff membranes which are better than high cutoff membranes to protect albumin loss. We thought if we can use medium cutoff membranes instead of high flux dialyzers in our patients. But Yes, medium cutoff membranes is reported in the literature to offer some removal of middle uremic toxins, but it is also known that this medium cutoff membranes may result in some albumin loss. Of course, generally we don't observe an symptomatic clinically significant hypoalbuminemia, but still it may result in albumin loss, and our patients have already hypoalbuminemia. We know that hemodiafiltration as high volume, high convection volumes is needed to remove the uremic toxins. They may also cause albumin loss. It was not possible. We didn't think of changing the dialyzer in our patient. And further, when we look at the studies of crossover studies changing from high flux membranes to medium cutoff membranes, the medium cutoff membranes in many of the studies were not shown to offer more removal of inflammatory molecules when compared to high flux membranes. So our patient was already on high flux hemodialysis for 12 months, so we didn't think of changing to medium cutoff dialyzer for this reason. And there should be one other solution, which was very well explained in the previous talk. Yes, with dialysis we can offer diffusion and convection, but many of them may not be enough to remove the higher middle molecular weight toxins and protein bound toxins as well. And so a new technology, which we all know, which is based on resins, which is based on sorbent solid phase resins, may remove some of the molecules, and which we know from the previous reports. That's why we initiated this Hemoadsorption 130 cartridge for our patient, and we combined the intense use and stabilization use. In the first 2 weeks we used twice weekly, and for another 2 weeks we used it twice weekly. And I think I should underline that these cartridges should be first heparinized to decrease the risk of blood clotting, and also we have used them pre-filter. We located them before reaching the hemodialysis filter, and it is connected series to the hemodialysis filter. This is a high flux membrane which we use, and this is the cartridge. And also for rinsing and priming, we used around 3 liters of saline. And when we look at the changes at 1 month, we have seen that the hemoglobin level, which the patient had a very intense erythrocyte stimulating agent hyperresponsiveness, and the hemoglobin levels rise after 1 month, and also we saw a decreasing trend in PTH levels. There was a decreasing trend in interleukin-6 and TNF-alpha levels, which may not be very statistically significant. It is only one case, and there was a slight decrease in interleukin-6 and TNF-alpha. But I want to draw your attention to the reduction rate of kappa and lambda light chains after 1 month, which may have some value, which I will share in the following slides. This was an interesting animal model study in sepsis-associated AKI, and in this animal model of sepsis-associated AKI, the hemoadsorption was shown to improve kidney microcirculatory oxygenation and oxygen consumption, and it ameliorated tubular injury. However, in that study, the positive effect of hemoadsorption couldn't be translated to the decreasing levels of interleukin-6 or TNF-alpha. However, it was translated into the better survival of kidney injury with lower creatinine levels after using of hemoadsorption. That's why I should underline that many of the procedures with adsorptive technology may not always be translated into changes in the inflammatory molecules, but still we have seen a great amount of reduction rate in the free light chains in our patient. This was our study with medium cutoff membranes some years ago on COVID-19 patients, which is very well known with its hyperinflammatory potential. We have seen that interleukin-6 levels like decreasing levels of interleukin-6 was very well associated with better survival of patients. So higher interleukin-6, when accumulated higher, is when interleukin is accumulated, and when the interleukin-6 response is exaggerated, it may be related to more mortality in patients. So there is the importance of interleukin-6 levels. So we should, of course, monitor the inflammatory molecules in our patients. The decreasing trend in free light chains may also be important, because the free light chains, which accumulate in kidney in chronic kidney disease and even more in hemodialysis, may inhibit neutrophil apoptosis, which may increase the inflammatory response, because if neutrophils can't go to apoptosis, the inflammatory response is increased. And also we know that when increased free light chains is bound to neutrophils, they may secrete another pro-inflammatory molecule, which is interleukin-6. So shall we use the inflammatory molecule levels or symptoms change in our patients? I generally recommend using both, because we know that this is from our cohort, almost 40% of our patients report pruritus to some extent. And there is a very high burden of symptomatology in our patients, and as very well recommended by our guidelines, we should also take care about the symptoms of our patients, and the better quality of life may be as important as the levels of inflammatory molecules. I will share another case. This is a 50-year-old male. He had hypertension and chronic glomerulonephritis in the background. He had received renal transplantation 22 years ago, and after 20 years, he had his graft loss, and he was on hemodialysis again for 1.5 years, and he is again dialyzed with high flux hemodialysis membranes thrice weekly, and he is also on waiting list for a retransplantation, and he is using arteriovenous fistula. He has left ventricular hypertrophy with an intraventricular septum thickness of 22 millimeters, which is very huge, and it caused grade 2 diastolic dysfunction in this patient. He also had secondary hyperparathyroidism and hyperphosphatemia. In hyperphosphatemia, there is another pro-inflammatory molecule, the FGF23, which in normal kidneys acts as a phosphaturic hormone, but in end-stage kidney disease with decreasing levels of clotho, it acts on FGF receptor 4, and it inducts pro-hypertrophic signaling pathways, and it results in left ventricular hypertrophy, and it's related to higher cardiovascular mortality. This patient also had adequate dialysis. He had acceptable hemoglobin levels. However, he had very high phosphorus levels and with also high parathormone levels. And in this patient, although we were using almost 3 different phosphorus binding agents, we couldn't reach the target levels in this patient. And also he had left ventricular hypertrophy, which was worrying us for the upcoming days, because the patient was active daily. He was only 52 years old male, and he wanted to receive another transplantation to continue his active life. This FGF23 is another around 25 kilodaltons, and as I told you, with decreasing clotho, it may result in left ventricular hypertrophy, and it may cause heart failure, and it may increase cardiovascular as well as all-cause mortality. So thinking about hyperphosphatemia in this patient and thinking about her left ventricular hypertrophy, we want to do something to decrease her FGF23 level. Of course, it is very well connected to phosphorus levels, but in this patient, we couldn't have adequate phosphorus controls with extensive medical therapy as well as adequate hemodialysis with high flux dialyzers. Could we change to medium cutoff membranes in this patient? It may be it is another option that we can think, but in crossover studies, again, the medium cutoff membranes was not shown to offer more reduction rate in FGF23 levels. As seen in these graphs, in the crossover studies, the FGF23s couldn't be lowered by exchanging from high flux membranes to FG to medium cutoff membranes. And the patient was already on high flux membranes for the previous 12 months. That's why we again thought about initiating hemoadsorption cartridge, as we initiated hemoadsorption cartridge 130, and we again located it pre-filter. Again, we used it twice weekly in the first 2 weeks and twice weekly another 2 weeks. And we saw that there was almost more than 25 decrease in PTH levels, and we could have better phosphorus control. I also would like to again drive your attention to the excellent, the almost more than 50% reduction rate in free lambda chains, which we give importance, as it will decrease the inflammation burden further, because as told in the previous presentation, the inflammatory molecules do not act as single units, but they act in interaction with each other. So we should aim to decrease as much pro-inflammatory molecules as possible. So this was also touched in the previous presentation. For whom shall we initiate hemoadsorption? As seen in our patients in severe hyperparathyroidism with left ventricular hypertrophy, it was our option to initiate hemoadsorption cartridges. Also in microinflammatory state with high CRP levels, and in ESA, erythroid stimulating agents, hyporesponsiveness, of course in severe uremic pruritus or sleep disorders or other subjective symptoms that we can reveal with specific scales like restless leg or neuropathy. We may also think about initiating hemoadsorption. So looking to the future, I may share some research agenda, which is also in our agenda as a local working nephrologic university clinic. Maybe can we combine the MC medium cutoff membranes with adsorbers? Shall we act biomarker with the guidance of biomarkers? Shall we check interleukin-6, TNF-alpha, FGF23 levels? Or shall we just use the subjective symptoms burden? Shall we use personalized inflammation monitoring for each of our patients? Or how should be the session frequency? How often or how frequent shall we use the hemoadsorption cartridge? Of course, we are looking forward to seeing more results of randomized control trials on these topics. I would like to thank you for your attention. It was a pleasure for me to share our experiences with you.
Thank you very much, Professor Mart, for this highly insightful presentation. Your work has highlighted the potential of HA-130 absorption in modulating pro-inflammatory molecules, offering new perspectives for managing chronic disease and dialysis patients. The presentation sets the stage perfectly for our upcoming panel discussion. And we are blessed to have you stay with us as a panelist in the upcoming discussion. And thank you once again, Professor Mart. And it's my great pleasure to introduce our next distinguished discussant, Dr. Alma Matovic-Turkovic, specialist nephrologist at the Clinic of Nephrology and Renal Replacement Therapy, Clinical Center of the University of Sarajevo, Bosnia and Herzegovina, and lecturer at Sarajevo School of Medicine and Sarajevo School of Science and Technology. Dr. Alma is a dedicated clinician and academic, currently pursuing her PhD in nephrology. She is the author of 3 professional books and has published numerous research articles in both international and regional journals. In addition, she has actively contributed to multiple conference proceedings advancing a field of nephrology through both practice and scholarships. And our next panelist is Dr. Nguyen Minh Tu from Chorvey Hospital, Ho Chi Minh City, Vietnam. Dr. Nguyen is an attending physician in the hemodialysis department with extensive clinical experience in dialysis, management, and metabolic disorders in renal failure. He obtained both his master's degree and master's degree in international medicine, medical doctor master's degrees in international medicine from the University of Debrecen in Hungary and has been actively involved in research on bioelectrical impedance analysis and secondary hyperparathyroidism among dialysis patients. We are honored to have them with us today. Please join me in welcoming Professor Mort, Dr. Alm, and Dr. Nguyen to the discussion panel. Panelists, please share your insights and respond to questions from the audience. The first question is how to select the patient for EH130 treatment.
Thank you. Hello, Dr. Prozorovsky. I don't know if you can see me.
Yes.
Yes, we can.
Thank you very much for your invitation and for including me in this panel discussion. It was a pleasure to hear from Professor Mort and Professor Castellano to your lecture. It was really insightful and it was very knowledgeable. This is also a great question in order to select the patients for the HA130 treatment. First of all, we know that this prescription framework we follow is that HA113 is recommended for uremic patients who are on chronic hemodialysis treatment, meaning they are on this chronic treatment more than 3 months, particularly when the symptom burden is significant. So as we could hear on the first lecture, the initiating process of this hemoadsorption therapy 130 is prescribed in the way that we have an acute phase, and we prescribe this treatment 3 times per week in the first month, afterwards 2 times per week in the second month, and 1 time per week as a maintenance period for this chronic hemodialysis patient. When we select the patient for including in this therapy, we follow not just the laboratory objective parameters, we also follow their subjective feeling. First of all, we have certain uremic pruritus with a DUA score who is more than 12. Then we have sleep disorders, we have malnutrition, we have severe secondary hyperparathyroidism with a refractory hyperphosphatus as well. We have some clinical indications like refractory hypertension, restless leg syndrome, and peripheral neuropathy. All these indicators help us to screen for patients who are most likely to benefit from this treatment.
Thank you very much for sharing these insights. And
again, yeah, I'm sorry. Firstly, I would like to thank you for all the Professor Cozzolino and Dr. Ahmed Mort about your presentation. It's a pleasure to have to hear you to have the experience from the other country as well. For my country and my hospital is kind of in the special selection for the patients. Actually, we have a different approach compared to the other countries. Firstly, talk about the same approach. So last year, we still have the indication for hemoadsorption only for patients actually having hemodialysis more than 3 years. Right now, the indication is removed because we understand right now the symptoms, the sensitivity of the patient to the toxin, uremic toxin, are different between patient, and the symptom may come early as well. So the timeline for indication is removed. Right now, we focus mostly on the symptoms and the indicator, the uremic toxin indicator. For the indicator, it's the same with the other professors, and For the treatment, actually, right now, in Vietnam, we compare hemoadsorption together with the HDF online. So we use, for normal patient, we use HD high plus hemodialysis 3 times a week, and then we apply HDF and HA130 together. What I mean is that for a normal patient, when we initiate the hemoadsorption treatment, we're gonna do 1 time per month, but then we do other HDF online 3 times per month as well. So every week, the patient gonna have either one HDF online or hemoadsorption from the HA130. It's a bit different, and right now we are doing that because we are not sure about the advantages of HDF online and HA130 compared to each other, because some other country may prefer, like let's say in Japan, they prefer HDF online, and in Vietnam we are in the middle ground, so we are trying to take advantages of both methods. Right now, for my patient, some of the patient having severe pruritus or severe amyloidosis, the application of hemodialysis with HA130 and HGF online bringing quite promising result. So that's my experience in GRA Hospital.
May I add here one more comment?
Yes, please.
Very, very insightful comments from my colleagues. I wanted to look at the question from a reverse perspective. For whom not to select hemoadsorption? That is a question generally I ask to myself. So I think firstly we should make sure that our patients are having their end-stage kidney disease treatment in a good manner, very well. I mean, we should check about dialysis adequacy. We should check about the best evidence-based medical treatment for our patients at the same time. When we look at the symptoms, because like almost half of our patients have pruritus. Like when we look at the symptoms burden, like there is only a very very small group of our patients who don't have any symptoms. So the symptomatology is coming with a high burden. So first of all, I think we should make sure that our patient is having their adequate dialysis, not with low flux membranes, better with, it may be difficult in some settings, in some low income settings, but with the new high flux dialyzers, with hemodiafiltration, if our patients are already having their high flux dialyzers or hemodiafiltration, then I think all of those patients who still have the symptoms burden may be candidates for hemoadsorption.
Thank you for that comment. And maybe we can move to the next question. And the second question is about H130, is that symptom relief or lab results. What matters most? Please, maybe someone can start.
For this question, I completely agree with Dr. Ahmed Murd that we need to use lab result and the symptom relief together. So right now in our country, we also doing hemolysis based on patient-based. We are trying to move forward to patient-based treatments. So we focus mostly on the patients. But as I said before, some patients actually develop the sensitivity to the toxin quite late, some other quite early. I have some patients actually have very high beta-2 microglobulin level, but she didn't develop any symptom at all. So the question is, should I started the treatment for her for the hemoadsorption and HDF online? So what I did was I started the HDF online and the hemoadsorption treatment for her right away, just because the high level of indicator without the symptom, so the symptom may come late for the patient. So again, we need to use both the symptoms and the lab result is what I meant. Yeah.
Thank you.
Excellent point. Thank you. Sorry.
Thank you for the comment. So if I can just go on the previous question, because I didn't want to emphasize that we use this method on patients who are just on hemodialysis for 3 months. No, I just wanted to emphasize that this treatment is used on patients who are on maintains hemodialysis treatment. We did also a small pilot study with 50 patients, and we followed them up in a period of 5 years. And I have to say that the dialysis vintage of those patients was around 3 years. And I also absolutely have to confirm the thinking of Professor Mort from Turkey, that we have to try all the dialysis modalities previously before before introducing the HA113 cartridge into the treatment. And that is exactly what we did. We included patients who had all this refractory secondary hyperthyroidism with all the previous clinical indications that I mentioned earlier before. When answering the second question, it is important to say everything is important. We have to treat the patient as an individual. We cannot just treat the lab results. We also have to relieve the symptoms and also to manage lab results because the low clearance rate of some high middle molecules and protein-bound molecules leads to long-term hemodialysis complications, which can alter not just the lab results, it can also alter their everyday clinical functions. So in our small pilot study, we have a statistical improvement in the global Pittsburgh sleeping core. We have also some better improvement in the mental and physical component of the quality of life of our patients. And also in this group who use the HA130 cartridge, we have a better improvement of the PTH values. So it is important to emphasize not just laboratory results. It is important to emphasize the subjective feeling and this together in order to improve the patient's overall well-being and their overall quality of life, just shifting the focus from numbers to outcomes that matter most to the patients.
Can I make a comment? I think that the question should be symptom relief and or lab results. So because we need to look at least at one of these. So maybe for some patients, it's good to have a symptom relief. For some patients, improvement lab results. And for some patients, both of them. So we need to look for all of them. And with HA, of course, we can have data from one single patient. So for 10 patients, 20 patients, who cares? The importance is that the quality of life is improving, both from symptom relief and the improving lab results. Thank you.
I also agree. I think the symptom relief comes first. But we nephrologists, we love making calculations. So that's why we're really eager to see some changes in lab results. And so a combination of both will be very good for the patients and for us as well. But of course, the patient relief, the symptom relief should come in the first place because we are doing it for our patients.
Would anyone else like to comment on that? No comments, no questions? Okay, let's move to the third question, and it's about how does H130 compare to other blood purification methods? Who want to start? Professor Marx, maybe you?
Oh, Professor Cozzolino wanted to comment.
Well, I mean, this is something that I would say non-inferiority. I would not say superior. It's okay. We know that hemodifiltration is not possible in all our patients due for many reasons. So I think that I can make in 50% of my patients on hemodialysis. We have in our two hospitals 300 patients on chronic hemodialysis. So I think that hemoadsorption can be a good alternative for patients that cannot make a hemodifiltration. So it's 50%. That is not bad. And we already say that how are the principal application, the evolving role. I think that we need to try it. HA130 is a good absorption. I think that as I showed, the KAH probably will be better for the problem of the preparation for the heparin for our nurses. And this is the evolution of the thing. So I will say non-inferiority.
I also wanted to say that I would not compare them because it is I think, according to my point of view, it's an add-on therapy because there are some points that we can't reach with the conventional hemodialysis, even with new dialyzers and even with hemodiafiltration in some of our patients. So the protein-bound uromic toxins was very well touched in Professor Cozzolino's keynote speech. So I regard hemoadsorption as an add-on therapy. So I wouldn't compare it with the other dialysis methods. For me, it's an add-on therapy, and for some patients, we need it as an add-on therapy.
Yeah, I completely agree. In Vietnam, we also consider HA130 is a add-on treatment. Like Dr. Abedmer said, for the patient, firstly, we need to focus on a better treatment with the high plus hemoadsorption first, and then after that, if the patient have maintained dialysis for a long time and they're developing symptoms and as well as the increase in uremic toxin indicators, and SA130 is a add-on. But I would like to have to ask a question because I just share my experience with Vietnam situation. We are not doing comparison per se, but for me, it's a indirect comparison between HA130 and HGF online. Is there any comment from that? Like, do you have any experience between HA130 and HGF online? Is there any difference? And In Vietnam right now, we're doing both of them together. We're having good result, but yeah, for a small and middle country, we are not sure about that. So I would like to have some experience from yours.
It's not very easy to comment, but I think it to some extent depends on the convection volumes that you can reach. Like if you can reach the convection, the ideal convection volume, which is more than 20 liters, then I think that it has big advantage for the survival of the patients. But still, the symptomatology of the patients should be questioned. So I think there are a lot of points that we can learn from your experience in that sense. So it's not very easy to comment theoretically, but I still would like to see the convection volumes that reached, and the other parameters that we follow up, the phosphorus control, the parathormone, the symptomatology of the patients. So there may be many points that your experience can give to the literature.
Thank you very much.
Do anyone have any questions or comments? Okay, thank you to all our panelists for the engaging discussion and sharing your valuable clinical experiences. I am sure that the audience has gained important insights today. And to conclude our session, I invite Professor Giuseppe Castellano to provide closing remarks and summarize the key takeaways from today's presentation and discussion.
So thank you very much. As we come to the close of this very interesting session, I would like to sincerely thank all of our speakers. Very good work, really, panelists, and all the participants for your valuable contribution and active engagement. The discussion today, I think, highlighted both the challenges and the promising direction in patient-centered management of the dialysis-related complication through immunoabsorption. We saw really nice data that hemoadsorption can help changing the quality of life of our patient in dialysis, improving some critical problems like itching, sleep disorders, high beta-2 microglobulin, the malnutrition is also a problem, high blood pressure, etc. We have to detect these clinical indicators to our patient syndrome evaluation scale. We have to be, I think, really careful about this. And the long-term adequate food treatment is also very important for good management of our patient. Your insights and shared experience are truly appreciated. You can write your comments. You can send us an email. We hope that this meeting has sparked new ideas and strengthened the collaboration across all the region. I would like to thank you again for your time and for your support, and we look forward to seeing you at future events. Have a wonderful day. Thank you very much.
Thank you, Professor Castellano, and thanks again to all our speakers and panelists. This concludes our session, and we hope it will contribute to improved understanding and patients' care in hemoadsorption therapy. Thank you.
Bye.
Thank you very much for
Thank
your
you
time.
and goodbye. Have a nice day. Thank you.
Have a nice day.
Thank you
Bye
very
bye.
much.
Thank you. Have a
Nice
wonderful
day.
day. Bye. Thank you.